So if it works, something's got to be happening in the brain. Is it just a placebo effect? So there have been a number of studies that have looked at beta endorphins, which we know is a lot to do with reward, and a lot in the field that we're interested in here is the role of dopamine. And there's a lot been written. I mean, Ken Blum has done some phenomenal work when he talks about, his reward deficiency syndrome going back to the early 90s. He had a paper, we have a paper actually I've done some writing with Ken coming out, just got accepted yesterday, but really looking at the science. These are animal models. So dopamine we know is a really important, and this stuff called BDNF, or brain-derived neurotrophic factor, turned out we originally saw it in depression. It was a kind of a good biomarker. So Chuck Raison and a number of colleagues of mine have looked at this, but it turns out BDNF is playing a really important role in a whole variety of other things, including as a potential biomarker for addictions. One of the problems, and these are the hurdles that we see, and this is why I think we need to really pool our resources together. Those of us who are busy clinicians in settings where we can do this is working with those of us who might be in academic centers, because the number of subjects in the studies it's very small, and we have a very high dropout rate. Now, part of the problem is they were not well-designed trials. So it's easy. So I review for about 12 different journals, so I get to read a lot of other people's work. And some of it I'm thinking, shame on you, you wasted ink to write this on this paper. I mean, they're so flawed. And others say, oh, this is really exciting. We need to expand on that. So again, it's the quality of the science. Science, in and of it, you can pay money and get any piece of crap, really, published now. There's these online journals, so you pay them $1,500 and they'll get them published. It's kind of changed the game. It used to be when you got something published in peer review, it was truly peer reviewed. Now it's become a book of business. But it is what it is. It just means we've got to be a bit more vigilant on who was the author. We can't just read the results or the conclusions. We've got to really read the design, which is boring, but if the design was flawed, don't waste your time even reading the results. So when they talk about exercise, it's forced exercise versus training versus voluntary. The thing that they didn't put in here in almost any of the studies, we're doing in our studies we're looking at now, is we use a visual analog scale, which is real simple. You just do a 10-centimeter line, and you put like the most, you hated it, and it was the most enjoyable thing you ever did, 2 anchor points. And all they have to do is they just put a little dot or a little line through it, and you pull out a 10-centimeter ruler, and you get a very precise reading. We've done this for years, published this VAS analysis. It's done a lot in the pain literature, as I'm sure many of you are familiar with. And one of the things that we have to look at in these studies is how much did the individual enjoy the exercise intervention? Because I believe the enjoyment factor will have a significant effect on the variance and the outcome. And again, a lot of these folks are lost to outcomes, so you don't really know. Was it an ongoing effect? I mean, it's one thing. I remember in the days when you could smoke on airplanes. It always made me laugh. If you were in row 12, it was non-smoking, and then they had a curtain. And then row 13, you could smoke. So you'd sit there. Now, I'm a former jock, so I've never smoked. But I probably had a hell of a lot of codeine in my lungs because I remember sitting there, and my hair would smell like I just, smoked a pack of cigarettes. Because someone doesn't smoke on a 3 or 4 hour flight and then jumps off the plane and lights up again, does that mean they were a non-smoker during the plane? No, of course not. If someone, doesn't use for a weekend and then goes out and goes on a binge, does that mean that they were cured of that? No, of course not. And we talk about this role of what does it mean to truly have changed the behavior as opposed to modify the behavior because of some other psychosocial cue. In the current research race, again, most of the studies, if you look at, and I didn't go through all 39 million, but we did go through quite a few of them. They look at alcohol, cigarettes, opium, many of the things that we see. And my interest here, there has been some emerging, much better work, prospective trials, looking at eating disorders. Now, there was a paper that will actually be coming out later in the week that I just had a chance to review this morning, looking at eating disorders and weight gain in folks who are developmental disabilities, looking at autism patients, looking at young kids who have trisomy and other various forms of genomic disorders, weight gain's a big issue with them. So what we're seeing is finally in those, it's not just modifying the dose of an atypical antipsychotic, which is bumping up the appetite and they're putting on 25, 30, 40 pounds. It's not just trying to intervene with some type of exercise, but it's finding an exercise program that they will be able to do as a part of their autism or of their various forms of neurodevelopmental disorders. Fortunately, people are now looking at, so what's the biology behind this? And again, this BDNF, this thing that we thought was originally going to be just a great biomarker for depression, turns out for a whole bunch of other things. So BDNF levels change as people start to get better. That's a good biomarker. Cortisol, the problem with cortisol, this is kind of the mother of stress hormones, is virtually anything will affect cortisol. If you get suddenly startled, there's so damn many things that can affect it. Yet many of the studies will look at this as a marker. And it is a marker, it's one that's kind of difficult to control for. We're looking at glucose, endorphins, again, things that have a lot to do with our reward pathway, and then these event-related potentials, or ERPs. So this was a study that was done just a few years ago now, basically looking at the days of abstinence. And what I liked about this study is it demonstrates something that we all care deeply about as providers, and that's what happens when the patient or the client, I'm trained as a physician, so they're patients to me, but when they leave our facility. So it might be nice that they really had a great time, they loved the staff, they loved the food, they loved the structure that we're able to provide for them, but what happens when they go home? Do they stay clean? Do they stay sober? So what this study did, this looked at, and again, it was a very low end, but it's a proof of concept as far as I'm concerned. And this is looking, I keep doing that. This is looking at the percent days of abstinence. And what it shows us is that this was just an exercise intervention, is that we had a very nice, dramatic increase from pre-treatment. This is statistically significant during the 12-week exercise program. So this is nice. But what happened after the treatment? So they're no longer in the study. They're no longer in the treatment. Now they're back home and doing other things. And what they were able to demonstrate here is it persisted. They followed out from 6 to 9 months. That's a good thing. That's the kind of thing we want to see. Now what we really want to do is understand what is it that allowed this to happen, but more importantly, what allowed this to happen? Did they continue to exercise when they left? Because, I realized I really enjoyed doing whatever it is that they were doing there. Or I didn't like that, but I really liked the fact that I felt good doing something that I enjoyed doing. So the follow-up for this really means we need more data. But I think that concept is one that we really all need to take to heart. This is looking at combinations, and this is the mandatory slide that no one can read. Every academic has to put at least one slide in that no one can read. This is taken from an article. And basically, all you need to see from this one here is that, as we know with just about everything, is that exercise in combination far exceeded the effects. And in this, they were looking at cortisol levels with forced exercise compared to Valium. So maybe some people say, well, they're just a little less anxious. And what we're able to demonstrate, this study is not my study, what they were able to demonstrate, and again, these are laboratory animals, which gives us a proof of concept. We got this thing called the prefrontal cortex as humans that kind of modifies some of the things that our laboratory animals don't. So we have to be cautious to never overgeneralize. But it does give us something to say, maybe we need to look at this in humans. And clearly what we see here is the combination exceeded any treatment in and of itself. Looking at nicotine, again, looking at this kind of meta-analysis, which is basically just getting all the studies you can get your hand on that meet the criteria and then kind of analyzing them. So it's not really your own work. It's kind of putting together, lumping together other studies that are out there. These were 12 studies that Taylor and his colleagues, now a decade old, did. And again, the big thing for me, significant reductions in cravings following any level of exercise. Showed affect and effect increased the duration. If they liked it, it changed the way they felt, and it increased the amount of time they'd want to do it. This is why I think the literature has missed a bit of it, and we can fill in that gap by making sure that we assess, are they enjoying what they're doing? They might do it because it's part of the program, so they're being compliant while they're in the program. But if they enjoy it, the likelihood of them doing it. And the data is demonstrating this not just in one, but in 12 different trials done over a significant period of time. And again, what are we seeing? Reduction in withdrawal symptoms. Never a bad thing for folks that we're dealing with. Mood changes. We know that changes in mood can act as a trigger. To want to use again. Gets back to my negative reinforcement analogy. If you're depressed, if you're anxious, if you're bored, a whole bunch of affects that aren't necessarily on the positive side can form as triggers to use again, whether it's using drugs and alcohol or food or whatever addiction might be going on. Increased mood, less depressed, decreased anxiety. These two affective states, very, very important in understanding relapse. Again, we can measure this in changes with BDNF. The increased time to kind of, choose to smoke varied by the group. So we were seeing a generalization effect beyond just the primary addiction. This is, again, these are just the studies, and anybody who wants the slides, you're more than welcome to have copies of the slides. There's nothing about this. But looking, again, at a number of studies, not just a study, but this was Roberts about 4 years ago now, looked at 15 studies and found that pretty much the exact same thing that Taylor found. Now, what I like about this is now we're starting to see a body of data that's demonstrating the same thing. Then we can have a greater level of confidence that maybe we should be looking at this as well. With opiates, and again, a little more recent study, forced exercise versus clonidine versus a combination, again, animal models. But what we're seeing is the positive effect of exercise, again, without getting into an analysis of all these, is we need to have that menu. We need to put it in. I have yet to find a patient population, including geriatric patients, who might have orthopedic issues or rheumatologic issues, where exercise cannot play a role. One of the things we found in our elderly population, in a study that we did in Los Angeles, looking at getting elderly patients doing water aerobics, which has become very popular. So you don't even have to know how to swim, but when you get into that waist-deep water, that you take a lot of that stress and strain off knees and ankles, and you don't worry about falling and breaking a hip, because if you fall in the water, the worst thing you want to do is get your hair wet. But the role of an enjoyable water aerobic program, turns out in the geriatric world that's becoming more and more popular and more effective in treating mood disorders, where it's been looked at predominantly. They've looked at measuring blood glucose. Why this is important is when you look at blood glucose in the brain, it has a whole lot to do with how we think, feel, and behave neurocognitively. So one of the things that we measure in the concussion world is changes in blood glucose levels getting to the brain post-mild concussion. And those changes relate directly to the post-concussive period. Here's the BDNF data, again, demonstrating that 10 days, so we're not talking about, like a 6-month training program period, but 10 days voluntary exercise, BDNF inhibitors were given, so we're trying to block this. And interestingly, what we found, there's this interesting thing called TRK-B mediated intervention. So an article came out last week from the Chinese research group, actually a very excellent Chinese research group from Guangzhou, looking at stem cells derived from adipose. And it turns out that there's a combination of some things that might have a direct effect on mood and behavior in certain neurologic conditions. So we're going to start a protocol looking at that in regards to head trauma and how it is modulated by drug and alcohol. So we've got an interest working with the NFL Players Union, the retired players, looking at, so what is the effect of someone who's using alcohol, less so drugs, but alcohol on a fairly regular basis. It's just part of the culture of sports, and how that modulates the impact of mild repetitive concussion. In animal models, we've been able to demonstrate that alcohol plays a pretty significant role. You get what's called the kindling sensitization phenomena. Basically, it takes less of a ding to have more of an adverse effect in regards to brain functioning and development of some abnormal proteins within the brain. So we were, again, able to demonstrate that exercise increased BDNF levels in both dependent and non-dependent groups. That's a good thing. BDNF goes up, it's like having high HDL versus high LDLs. You want those protective. Ralston, a much more recent study, a little bit larger N, which is good, looked at 60 minutes of structured exercise program, 3 weeks, 8 weeks, health education, looked at some Beck, depression and anxiety inventories. Again, exercise significantly reduced both depression and anxiety as compared to education and control. This gets back to the idea that just training people, just giving them data is not enough. I'm not saying that education isn't important. It is an important part of what we do, but it has to be tied into that affective piece if we want it to modulate that psychomotor or the behavior. It's similar, not the same Chinese group that just came out, but another very good group from Guangzhou. Small N study, but they looked at, again, our big issue here is this craving piece, reaction time, so a number of things. These are EEG type activities that they'll measure. The big thing that I'm interested in is the craving was attenuated for 50 minutes after exercise. So there was an ongoing effect, and that craving scores were reduced across the board. So again, these are just, I wanted to share with you data that I think really allow us to say, maybe we should be thinking about this. There's some clinical science behind this. These are just looking at kind of EEG activities. I'm not so sure how well these play out for our population, but what it does show is that there is something going on in the brain and the electrical activity of the brain that help us to understand why we're seeing these positive effects. This is, again, getting back to Wang's data, and here we're seeing craving data. And if we look at the exercise session here, and this is what we want to see, so this is like golf, lower is better, that with an exercise session related to this control group, a highly statistically, you can see the control bars there, highly statistically significant in regards to craving. And again, getting back to my opening remarks, if we can stop or eliminate or reduce cravings, all of our other interventions are likely to be more successful. All of our psychoeducation and our psychotherapy and family therapy, everything else we do will be more effective if we're able to continue to decrease cravings. Well, we talked about the important role of dopamine, and I think dopamine is one of the key, not the only, but one of the key elements in regards to the reward system. And again, Nora Volkow and others, Ken Blum's done some wonderful work in this area, but this modulation of dopamine. And it's not, getting to too much dopamine or too little. It's kind of like the three bears. It's got to be just right. So what we're talking about is this balance. And what we're seeing, if you look at some of these animal data and some of the preliminary clinical data we have, is that exercise doesn't give us this big, massive influx of dopamine, which has actually put one at greater risk, or precipitous drop-off, but allows us to get what we call in medicine that homeostatic level, that right balance. Just like blood sugar. You don't want your blood sugar shooting up to 200, nor do you want it dropping down to 50. You want to keep it at that therapeutic level, right around 100. And that's what we're seeing with exercise. We don't run the risk with an exercise program. Even when we talk about the runner's high, which has been written about, that has a bit more to do with opioid receptors, but it maintains that physiologic balance, which is why I believe we see this protracted effect, because once we hit that balance point, Mother Nature likes that. She likes that balance point. Then she doesn't have to go into all kinds of compensatory mechanisms to try to achieve that balance. So in our blood sugar analogy, blood sugar goes up too high, your insulin pumps out from the pancreas, pancreas pumps out a whole bunch of insulin to bring it back down. Today, too hot. Mother Nature doesn't like us being too hot, so we sweat. Sweat evaporates, we cool down. If it's chilly, because in our room the temperature was set at 66 last night, we forgot to look at it, we woke up shivering. Kind of a waste of electricity given this heat. But the shivering is Mother Nature's way. We're cold, we'll shiver, muscle movement will increase temperature. So Mother Nature likes to have that balance point. Anytime we're at that balance point, other interventions are likely to be much more effective. And again, we've demonstrated that exercise increases striatal D2, D3 receptor availability. This has been directly related to craving. So hopefully we understand that exercise, particularly in the eating disorders, and again, I think in all of them, I have a particular interest in some of the eating disorders. Now, we have to be cautious because we know that exercise can have the downside. Most of us who work in this space have seen patients who have become addicted to exercise. Oftentimes, with our anorectic patients, usually not with our bulimic folks, but it can play an important role. But like every other intervention we do, we have to use it wisely. We have to use it based on what we know to be therapeutic. And there are certain patients that we have to restrict. Certainly our anorectic patients who are out, running 10 miles and trying to live on 400 calories a day. That's not a healthy thing either. We know that's the highest risk group for mortality within all of psychiatry. So there is a downside. It's not a panacea. Nothing is. Why the heck I keep doing that? But I think when used appropriately, the upside is pretty dramatic. Numerous studies on some of the negative aspects. Again, what they do is, like any other drug, it's got to be controlled. This is where the education can hopefully be helpful. You know what, so you enjoy a piece of cheesecake, one piece of cheesecake every once in a while, no big deal. Sitting down and having half a cheesecake every night, probably not so good. So exercise has a positive role, but we need to help our clients, our patients that we're working with, to understand how to do it so that it's fun, and how to do it in a way that's helpful and therapeutic and not going in the other direction. I think that's, this is, again, study, look, just a 15-minute walk. I mean, does someone have to engage in, an hour and a half of intense exercise? No. I think what they have to do, though, is understand that, doing exercise once every 2 or 3 weeks is not going to really make a difference. That it has to be part of the regular, healthy, enjoyable lifestyle. And we all know that when we deal with our folks, we're talking about making lifestyle changes, not just stopping to use for a couple of weeks or a couple of months, but really changing the way we think about how we choose to live our lives, what's important to us, what we're going to do. I've been a big fan of exercise programs as a social event. So we'd go out, we could go out for a walk with my best girlfriend or best boyfriend, and we chat about things. It's almost kind of a support group in and of itself. But exercise that takes place within the context of something that is otherwise a very enjoyable activity. So a 15-minute brisk walk versus just resting had an impact on chocolate consumption. Now, I can tell you my mom is clearly a chocoholic. And now she's 85 years old and still cuts her own grass and goes swimming 3 times a week. But for her, a day without chocolate is a day not lived. Now, what we can do is to make sure that my mom now hopefully knows that, enjoy a piece or 2 of chocolate doesn't mean that she has to scarf down, multiple pieces in the course of a day. Exercise almost half the kind of self-admitted use of consumption while performing a computerized task, and exercise increased the levels of affective activation, helping with mood. And there have been a lot of studies, and some of the compounds, there are a lot of active compounds in chocolate, fascinating stuff biologically, but what we find is that chocolate does have, in some people, a pretty robust effect on that mesolimbic dopamine, that reward pathway, but it varies. And if you look at women, it varies again on menstrual cycle phase. So if you look at women when they self-report, the enjoyment factor, and we all know we got a whole bunch of scales that we can measure the enjoyment of something. The enjoyment factor of chocolate in women varies. It's about 12 to 18%. If you look at the studies, Dave Rubinow, Pete Schmidt, and others, folks I worked with years ago, as a function of menstrual cycle phase. We talked about the role of yoga. I mean, this is becoming very, very, it's a kind of a hot thing, not to steal from Bikram yoga, and I think it clearly has an important role. But I think it's also important that we make sure we ask the patients to get involved. I've seen patients who said they went to yoga, they really couldn't stand it. And maybe some of them went and they liked it and it did well, but forcing someone to do something on an ongoing, I say, well, I tried it. It's like you tell your kids, try broccoli at least once. Don't say you hate it until you try it once. They try, maybe it's not so bad. So I'm not saying that we shouldn't use it, but I don't think this idea of one form of exercise will work in everybody or should be used in everyone. I think having a bit of a menu of things. The key to the exercise is to get that heart rate up to about 70, 80% of max. Keep it there about 20 minutes, 3-4 times a week. You got it done. It doesn't have to be related directly to any particular thing, even though there's actually some good data talking about Bikram yoga. It reminds me of a clinical vignette. So I did PMS studies with Behavior Endocrinology Lab back at the NIH years ago. So I had this woman who went through this very long, intensive study. So we're trying to understand the role of the gonatosteroids in mood and behavior. She finishes the study. She comes up to me at the end of the study and she says, Dr. Barron, I want to ask you, really appreciate all the time and effort we've done in this. I said, what form, and it was actually an exercise, was one of the interventions that we had, so this is going back again to the late 80s. And she said, what would you recommend that I do? Now, this was when I was young and very foolish, and I said, well, you know, getting access to pools in the Bethesda area, particularly in the winter, not so good. I said, why don't you try like to jog? Now, why did I say that? Because I was a former swimmer who now was a jogger. I'd like to say a runner, but I really wasn't. But it was something you could do. You could run around Rock Creek Park in Washington. It was fairly easy to do, and most of the year you could do it. So she walks out, comes back 2 weeks later for a follow-up for the studies that we've done, and she gives me one of these walking in. And I said, you know, what's going on? She said, Dr. Barron. I thought, oh my God, I missed the diagnosis. This woman was depressed. I should have been treating her depression. I said, well, tell me what's been going on in the last couple of weeks. And she says, you know, you spend all this time with me, all these months. I ask you one thing, what should I do as far as exercise? And you smiled at me and you said to go out and jog. And I didn't have the heart to tell you, I'd sooner be dead than jog. And I haven't jogged one step. And I feel so bad. I said, I feel bad. Shame on me. I said, let's kind of roll it back like the commercials they have, you know, with the, you can do the direct TV and roll back. I said, let's roll back time 2 weeks. I said, now tell me, what form of exercise do you like to? She said, really not any exercise. I said, let's go back in. What do you like to do that raises your heart rate up and keeps it there for a while? And she says, I love to dance. I said, that's great. She said, Dr. Barron, I got a big problem. She said, I've been married for 22 years. My husband hates to dance. I can't get him to go out dancing with me. I said, okay, fair enough. I pulled out a script pad. I wrote on the script pad, patient must dance 3 times a week for 20 minutes with or without husband. And she laughed and she took it home and she came back and literally she and her husband ended up signing up for Arthur Murray. I don't know if they still have Arthur Murray anymore. They took dance lessons and she said, you know, things are great. Our marriage has never been better. What's the point of that is have it be fun. Have it be enjoyable. But make sure that it meets that minimum criteria, i.e. get that heart rate up, keep it up there for 15, 20 minutes. And it varies with age. Varies with cardiac status. We also want to make sure that patient is physically healthy. You ever see all the ads for the PDE drugs, for the sexual performance drug? Make sure your heart is safe enough or healthy enough for sex. Like how many guys are going to say, no, my heart's not healthy enough for sex. I'd sooner die than report that my heart isn't healthy enough for sex. But the reality is we should make sure that if someone's going to get involved with an exercise program, that they do get some baseline, very simple baseline screening. They don't have to go through the $1 million workup. And there are many activities that you can do that aren't related to, weightlifting or jogging. But the key here is have them like it, make it enjoyable. So to summarize, we're doing pretty well. See, you were supposed to give me oh, look at that. See, you got to be more exposed. So there's some exercise shown to alleviate issues in substance abuse, eating disorders. It can be used as a supplement, should be used as a supplement, as a treatment modality. We know some of the things that are going on, particularly within BDNF and the dopamine, a lot. Dopamine is really important in all forms of addiction, eating substances, other forms of process addictions. All methods of exercise have shown to be effective. It's not like it's like, well, this exercise worked, but not that. What works is the one that the patient likes and will continue to do and fits within the realm of your treatment program. I mean, you can't do, if you don't have a pool, you're obviously not going to do aquatics therapy in your programs. And future research really needs to consider what else we can do and how we can work together. So those are really small because I tried to fit them on one slide. These are all the references. If anybody wants a copy of the slides, you're more than welcome to them. Let's close. I know it's been a big crowd, and I appreciate you hanging in there with me for such a long talk. If there are some questions or comments, we'll close with that. And if not, enjoy the rest of the conference. Again, if you're going out and you're going to get some jogging, put good shoes on. Don't burn your feet like I did. Thanks very much. I think we had one of our AV folks had a mic that if someone had a question or a comment that they wanted to make, up, there we got it right up front. Perfect. Anybody have any, gentleman over here? Please feel free to go too. If you have another session coming up, don't feel you have to stay. I really appreciate so many people hanging in there for the whole hour and a half. Yes, sir.
Thank you. Are there any MRIs that show that somebody who's addicted has some, like let's say, lower blood flow from a SPECT scan, and then after they've been running, say, an hour a day several times, that they have more blood flow and they've been able to get free of their addiction? Like, is there a direct relation between neurogenesis and synaptogenesis and being free of addiction?
Yeah, it's a very excellent question. What we're looking at now is people talk about getting MRI scans. So kind of, it's a lot different than when it was when I went to medical school and you just get like a picture of the brain and look for a space-taking lesion. Now we can look at the way the brain functions. And the studies that we're looking at now, in fact, one of our research group at USC we're looking at this, are looking specifically at some advanced MRI imaging. We call it DTI and DWI, I don't know if you do imaging work. So if you use diffusion weighted imaging and diffuser tensor imaging, these are just kind of high-end versions of MRI. And what we do is we combine those. So we're the first lab to do that. So we're very excited about this data with something called spectroscopy, which tells kind of the functioning. So we're able to meld those two things together and look at that, exactly what you're talking about, is how is the brain functioning? What you don't see very early on is kind of changes in the brain morphology. But we can measure, there's a process called BOLD, which is just BOLD, which is brain oxygenated loads. So we can measure that, and you're exactly right. What we're seeing is when you have an effective response, you can measure those changes. So what we're looking at now, so particularly within spectroscopy, you can look at very specific things like dopamine effects. You can look at a whole host of other things. And that's what we're seeing. We're seeing a change in the functioning of the brain as a result of various interventions. And that's cutting edge, and that's kind of, there are a number of NYU's looking at this, a couple of other places. And what it's been gratifying is that we can demonstrate, yep, there is a biology that's explaining why this is working. Great question. If nothing else, again, thanks very much.